Thank you very much. Thanks to the organizers for inviting me. And just in keeping with the spirit of all the cute little jokes everyone's been making, so we save winners, okay? So you guys have hopefully finished your postprandial sleep. Stay awake. There's good drugs in dermatology. They work, okay? So let's see if I can figure out the stuff. Okay, there's my conflicts of interest. So our learning objectives: to identify new oral and biologic therapies for the treatment of moderate to severe psoriasis, to discuss the role of IL-17 pathway in the pathogenesis of treatment, and to describe the safety and efficacy of the newest oral agents in the treatment of moderate to severe psoriasis, oral and biologic, excuse me. So when we think about a patient with psoriasis, not every patient with psoriasis needs a systemic approach, but clearly these kinds of patients with this level of disease activity should not be treated with a topical corticosteroid, which is what way too many of my colleagues do on occasion. So trying to just think about the pathways here, what I'd like to do is I'd like to take you through. This is just, the classic antigen-presenting cell T cell and the co-stimulatory molecules, and then the molecules that the T cell makes, including the 17 pathway, TNF-alpha, IL-12/23, IL-8, some of the markers that we've worked on over the years. And some of the earlier drugs have actually targeted co-stimulatory molecules in dermatology, and several of those have disappeared actually from use just because they haven't actually been effective enough, or if you're looking closely at the progressive multifocal leukoencephalopathy slide that was just shown, because of a side effect. So a drug called Efanesoctocog blocked this pathway here, but it was removed from the market when patients with psoriasis developed PML. And then this pathway, the LFA3-CD2 pathway, was targeted by another drug, Etanercept, which was one of these drugs that worked very nicely in a very, very small subset of patients. And so recently, the company just removed it from the market because I think there were probably about 4 dermatologists in the country still using it. Okay, so we're going to talk about Ustekinumab. Ustekinumab's been around for 3.5 years now for the treatment of psoriasis. It's very high efficacy. It's infrequently dosed. It's not contraindicated in MS. It's in fact been studied in multiple sclerosis, so it's a great advantage over the TNF inhibitors, which we use a great deal of to treat psoriasis patients. Its disadvantage is it's new. And when I say that, I mean in regards to, for example, a new drug like Efanesoctocog, which was originally indicated purely in psoriasis, and then we were surprised 4 or 5 years down the road when we saw patients developing PML. So we're a little bit leery, shall we say, of using a brand new drug when it just comes to the marketplace in psoriasis with small number of patients. And I'm certainly much more comfortable when I have a database of, not a database, but I have a experience of 1.5 to 2 million patients like we have for several of the TNFs. And it's also, Ustekinumab's being studied in psoriatic arthritis, and I know the data has been presented at the rheumatology meetings, but it's not yet approved. So it's dosed at either 45 or 90 milligrams at very nice long intervals, so week 0, week 4, and then basically every 12 weeks thereafter. And it's a weight-based dosing such that smaller patients, psoriasis patients, are notoriously overweight as an association with metabolic syndrome, obesity in these patients. So a small subset of our patients get 45 milligrams, but most end up getting 90 milligrams. And we get very, very nice improvement. PASI 75 is probably the large majority of you know is kind of the standard tool used in psoriasis clinical trials to measure success. It means the percent of patients who have achieved a 75% improvement in their severity of their psoriasis. So short term, we're at, the numbers are about the same, about 70% over a longer period of time. So this was actually one of the first comparator trials that we have had in dermatology to look at more than one agent. So this was a comparator of Ustekinumab against what had been the old standard, Etanercept. And basically the results of this study showed that even when you pushed Etanercept here in this trial, they used it at 50 twice a day continuously, as many of you know. Etanercept's approved in psoriasis for 50 milligrams twice a week. I must have said twice a day. Twice a week for the first 12 weeks. And then you have to step down the dose, whereas in Most of the rheumatologic indications, you don't usually have that step up. So this was pushed. The Etanercept dose was 50 milligrams twice a day. And if you compare to Ustekinumab at the highest dose, there was 73%, big difference. And even when we push out to PASI 90, percentage of people whose psoriasis is 90% better. What does 90% better mean for a psoriasis patient? The way that a colleague of mine describes it is you can run around naked and no one will know you have any skin disease. Okay, what about side effects? This is the results of the 5-year follow-up studies, just looking at serious infections, non-melanoma skin cancer, malignancy, and MACE events in the Ustekinumab-treated patients, events per 100 patient year. And basically, you're all over the place, but what you don't want to see is this. You don't want to see a rising trend. So the trend is kind of all over the place. No increased incidence of any of these toxicities in the 5-year data looking at Ustekinumab. So the IL-17 pathway has been an area that has developed and is of great interest in psoriasis. So there's evolving evidence that these Th17 cells, which are really a subset of CD4 positive T cells, play an important pathologic role in psoriasis. The Th17 cells secrete many cytokines, including many members of the 17 pathway. And we've looked at skin and blood of patients, and they have elevated levels in both areas in psoriasis, and the elevation actually correlates with disease activity. So IL-17, much like this is very analogous data to what we learned many years ago when we were looking at the role of TNF alpha in psoriasis, basically increased levels in the blood and in lesional skin. So this is very interesting. So here, now we're going to look at blocking the IL-17 pathway, and as you heard a little bit about, you heard mention of at least one of these drugs by name. There are 3 different drugs that are out and available in trials. They're all actually in phase 3 trials, and I'm going to show you the results of the phase 2 data. So they're all challenging names, of course. This is the best one, Ixekizumab, humanized IgG4 monoclonal antibody that neutralizes IL-17A. And then Ixekixumab, fully human IgG1 that neutralizes also IL-17A. And then Brodalumab, which is a fully human IgG2 monoclonal antibody blocking the receptor, the IL-17A receptor. All right, so let's look at the data first for Ixekizumab. This is the phase 2 data. And this is actually published in the New England Journal. And we'll have as a typical phase 2, a bunch of different doses, but up at the highest doses, up at 75 and 150 milligrams, we're getting PASI 75s up at almost 80%. I better be nicer to this side of the room. If we look actually at PASI 100, so this has never been looked at before because the numbers are sitting around 0. They're sitting around 2%, 4, 5%. We're looking at PASI 100 scores now, which is basically a dermatologist goes over the patient with a microscope, okay? And you can't find anything anywhere. That's PASI 100. So the 2 highest doses here, we're looking at PASI 100s of about 45, 55%, which is absolutely amazing. It's an incredible result for these patients. What about side effect profile? Not much going on here, really. There's nothing, as we go up in dose, there's nothing that's showing really a dose response that's looking worse at the higher doses. So far in relatively small numbers, typical phase 2 trial, we're looking at 150-ish patients. So you can't be too reassured by that kind of data, but certainly promising. What about the next drug, Ixekizumab? So here's the data for PASI 75 and PASI 90. So at the highest dose, we're getting an 81% PASI 75 response when we go with this highest dose at monthly. Same thing, about another 150 patients in this trial. And the side effect profile, same story, busy slide, but same story. The placebo's over here on this side. As you go up in dose, you're not really seeing a whole lot that's dose responsive, suggesting that things are that are likely to be worse because of giving increased dose. And then the last drug, the Brodalumab, the IL-17 receptor antagonist. This is the phase 2 trial of showing, again, PASI 75 and PASI 90. Here we're up in the 75, 80% of patients having these kind of fantastic responses, 75 to 90% improvement, and I think I have a 100 as well, so a PASI 100. 62% of the patients at the highest dose here showed PASI 100 type of numbers again, so rather remarkable. What about the side effect profile? Same story here. We're looking at, as you go up in dosage, there's not really a whole lot of difference in terms of increased incidence of side effects. So again, doesn't seem to be anything jumping out. And again, this is a slightly larger study here. We're up at maybe 200 patients or so. So what else is out there? What else is out there? And I should tell you, in the phase 3 trials, basically they're choosing dosages to go forward that are at the highest levels. I think all 3 of these IL-17 drugs, in fact, the phase 3 trials are looking at 2 different doses and different intervals. And as a typical phase 3 trial, what they do is they get everybody better. There's a randomized placebo portion, typically 12 weeks. And then after the people who have gotten better, there's a randomized removal of drug, and they watch and see how long until people flare, and then they will redose them again. In some of the studies, they'll redose them at different intervals and see how what's the lowest interval that you can get away with, if you will. And that's certainly important information that we want to learn about when we're down the road when we're using these drugs in clinic to take care of our patients. So you probably are familiar with Apremilast. That's made it into psoriatic arthritis world a little bit. This is a phosphodiesterase inhibitor, and Tofa, of course, you guys are very familiar with. So basically, this is one of the small molecules, and it inhibits phosphodiesterase. So basically, it blocks the cyclic AMP pathway, and basically what you're doing is through a whole bunch of different pathways here that I will not bore you with. You're basically blocking NF-kappa and turning off a lot of different development of a lot of different inflammatory cytokines. So here are the cytokines: TNF, IL-2, 10, 17, 23. So it may be a little more, little less immunosuppressive perhaps than some of the other molecules, and than some of the biologics, maybe. We have more to learn, really, to be confident about that. But it's certainly the data that I will show you here in terms of treatment in psoriasis. So this is an oral drug, and we have an efficacy of about 33%, which is PASI 75 at week 16 here of about 33%. And if you look at the PASI 50, which is a slightly lower bar, you're looking at about 60% of the patients. And then we won't bother with that. That's just another measure, not critical. And then in terms of the side effect profile, this drug does have a little bit of GI intolerance, so a little nausea and diarrhea, but most of the time, most of the patients don't have enough of a problem with it that they're discontinuing this therapy. So I think that it's important when you're looking at a drug, obviously, to know what you're dealing with, and it's good that we have this data knowing what we're dealing with here. In terms of the JAK kinase inhibitors, these are in phase 3 now. That was actually the phase 3 data. I didn't make that clear. That was the Apremilast phase 3 data. Those are the results of the phase 3 data. So of all the therapies that I'm showing you this morning for new emerging therapies for psoriasis, that is the one that's the furthest along of any of them. So it might be the first one to come out if you can make any assumption like that, which in today's day and age with the FDA, you probably cannot. So the JAK kinases, we'll skip this. You guys know all about this. So Tofacitinib is a selective JAK3 inhibitor that also blocks JAK1 a little bit, and JAK2 a drop. So here are the results at the different doses from Tofa 2 twice a day, 5 twice a day, 15 twice a day. And basically, you're getting a pretty significant dose response, and you're getting up to PASI 75s of about 75, actually, at the highest dose. So we'll see, again, when FDA weighs in on this. We'll see what the phase 3 shows. This is the phase 2. But when the FDA weighs in on this and what dose they end up giving us, how excited we'll be, shall we say, in terms of what kind of drug we have here, how well it works, and how efficacious it is in treating our patients. In terms of the side effect profile, same kind of story, really. Not a whole lot going on here that seems to be dose dependent. Maybe a little drop more nasopharyngitis and maybe a little bit more sinusitis, but but looking pretty good and quite well tolerated in the trials. Okay. Actually, there was something else I wanted to mention that I neglected to put in the slides, and it made me think about it, so I'll just add it now before I conclude, which is there's another therapy that you guys, probably most of you haven't heard about, that got very far in phase 3 trials in psoriasis, and then it was dropped. It was called Brodalumab, and it was a cousin of Ustekinumab, and it was an IL-12/23 inhibitor, and it worked kind of at the level of the IL-17 inhibitors in psoriasis, really, really very, very well. But when they were analyzing the phase 3 trials, they found actually that this drug had a number of MACE events, perhaps increased risk of cancer, perhaps increased risk of infections, and so this drug was actually dropped and has not gone forward further. But I think that it raises pause. It's not 100% clear when the data is analyzed whether the increased risk of MACE events that occurred is solely due to chance or is actually statistically significant. But in any event, given a disease like psoriasis that in and of itself is not inherently, routinely, and everyday life-threatening, it was decided not to go forward with that therapy. But I think it's a very interesting and important therapy, an important story. I'm sorry I didn't think to put the slides in, but better late than never. So basically, in conclusion, looks like I've saved you time. I don't know if you're running late or not, but you now have an extra 8 minutes. Many new oral and biologic therapies have been developed for patients with moderate to severe psoriasis, and these therapies will continue to improve the treatment paradigm for patients with this disease. And I think that we're very lucky, especially with what you just heard from the previous 2 speakers, that here's an area where therapies seem to really be coming together, and we find, it's going to make it more challenge for us as dermatologists to be able to decide, well, which is the right therapy, and the balance of comfort with 1.5 million, 2 million patient years of therapy versus a brand new drug. So I think a lot of times we end up going with, we'll stick with the old stuff when we don't know what's going on, but in those tough resistant cases, we'll certainly consider new therapies. And I will stop there. Thank you very much.